Okay. Well, here we are. Today we're going to talk about the respiratory system, and just to give you a sense of how far we've come from the Neolithic age that Colby was in terms of its respiratory anatomy back in the day when I first arrived to the wonderful world of molded plastic that we're now in. This is what we used to, when I first got here, is what we used to learn the anatomy on it. And while it is kind of charming to use this thing that looks like it came from the Roman era, the classical era, I am trying to slowly update the library of models that we have. Nonetheless, this model is useful, and I'm keeping it in the PowerPoint just because it is a nice kind of artifact that we can use and still shows lots of anatomy. That's lots of salient anatomy. All right, so let's start walking through the respiratory system. The respiratory system in general is broken up into the upper respiratory system and the lower respiratory system. This model here does an excellent job, or at least a mediocre job, of showing the features of the upper respiratory system, and then all the lower respiratory system, gross anatomy, macroscopic anatomy, is going to be these models on the outside benches. There. So let's take a look at the upper respiratory. I don't have any of this labeled, but that's okay. We can walk through it. There's the nasal cavity and the oral cavity. First, the nasal cavity. You can breathe through either of them, and it is ideal to breathe through the nasal cavity. People do breathe through the oral cavity when they're talking a lot, so you can say that you had a mouth breather teaching you all semester, because I don't really shut up for 4 hours straight. But normally a person gets to breathe through their nose. The external nares, N-A-R-E-S, the nares is naris, N-A-R-I-S, is the singular naris, N-A-R-E-S, plural. Those are the words for the openings in your nose, that what we call the nostril, the nares, that lead into the nasal cavity. In the nasal cavity, you're going to have a superior, a middle, and an inferior nasal concha, C-O-N-C-H-A, concha. Inferior, middle, and superior nasal concha. Also called the turbinates, T-U-R-B-I-N-A-T-E-S, the turbinates. The job of the turbinates is to mix the air up and get the odorants to adhere to the wall of the nasal cavity where we can smell things. Also to try to trap any particulates, smudge, crap that would clog up our lungs. It's kind of like the filter for the air we breathe. And then at the back of, so you can see here, there's this opening between the middle and inferior nasal concha. This aperture right here is called the internal nares, the same spelling as with the external. So that's the external is the entryway into from the outside, and then this is the entryway into from the inside. We pass from the nasal cavity through the internal nares into the pharynx, specifically the nasopharynx, N-A-S-O, nasopharynx, pharynx, P-H-A-R-Y-N-X, pharynx. The pharynx itself is broken into 3 regions: the nasopharynx, the oropharynx, the laryngeal pharynx. We'll go through these other two in a bit. In the nasopharynx, there are really only a couple anatomically significant features. There is the aperture for the auditory tube or the Eustachian tube. You can be seen on this model. It can be seen on some of these other models. It's certainly on this plaster cast thing here. This thing's probably like 100 years old. And then you can't see it well in this diagram, but it would be on the posterior margin of this nasal pharynx. You're going to see this tissue drawn right here. All right, this is what we would call the pharyngeal tonsil, otherwise known as the adenoid. A-D-E-N-O-I-D, adenoid. It's the pharyngeal tonsil. Right there, and it's lymphatic tissue. A tonsil is simply a cluster of, like a lymphatic cluster, sort of. It's a cluster of lymphatic tissue. Then there's the oral cavity. We'll talk about the oral cavity more in the digestive chapter, but you go from the oral cavity through this aperture here called the fauces, F-A-U-C-E-S, F-A-U-C-E-S, fauces. And that's just like if someone opens their mouth, you see the little punching bag at the back there, the uvula. And then if you follow that ridge of flesh from the uvula up around that rim is what the fauces is. You pass from the fauces into O-R-O, the oropharynx. It's just the same part of the pharynx. The pharynx is the back. And then you descend down to this portion here called the laryngopharynx. The laryngopharynx then divides into the esophagus, it goes down to the stomach, and then the larynx. We'll see some anatomy of the larynx in a much better model in a moment. Is there anything else on that? I don't think so. We'll have a better. Oh, here, an actual cartoon, a diagram. Life is so much better in cartoon. What's new here? So here's the internal nares, pharyngeal tonsil. Did I spell that right? P-H-A-R-Y. The auditory tube, nasal pharynx. I guess it points out. So this is what's called the palatine. P-A-L-A-T-I-N-E, the palatine tonsil. These are the tonsils that people usually refer to or have removed. My daughter had them removed in August. This is the ones that you can see that are sometimes enlarged, or you sometimes feel them. You have throat. There is another lingual tonsil that's hard to see. That's actually at the base. And then we get into the larynx. So the larynx starts with this epiglottis. The glottis, G-L-O-T-T-I-S, the glottis is it's the void space where your vocal cords are. See it. It's just the void space where the vocal cords are. Above that is this epiglottis, as the name would suggest, epi on top of or above glottis. And it's just a flap of cartilage that is normally open, but when you swallow, the act of swallowing depresses the glottis and obstructs the airway so that you don't aspirate or inhale any whatever it is when you're swallowing. That going down any food, liquid, saliva. The epiglottis is to prevent things from getting into the aperture of the airway. There is a fairly complex arrangement of cartilages that make up the larynx. So that your voice box is what the larynx is. This whole apparatus. There's a pretty complex list of cartilages. I'm not going to teach them all to you. There's even a more complex list of muscles, and I'm certainly not going to go there. But I will mention a couple of the important ligaments and a couple of the important cartilages. The most obvious one is what's called the thyroid cartilage. This is the large blue one painted on these models here that you can see. Let's turn around. Thyroid cartilage. And you have a nice laryngeal model. That one's actually mine. Mine's here, but I own that. And that one comes apart. You can take it apart and look inside, this is nice. There's a couple others. There's the cricoid cartilage is probably the most readily visible. Cricoid means signet ring, like a crown signet ring. We'll see why they call it cricoid in a moment, because it does, in fact, look like a signet ring. Is there anything else in here? I don't think so. We can see the hyoid. I had you guys look at the hyoid before, kind of tucking all the muscles up into the chin. So I was making fun of Mitch McConnell there. With several muscles, the digastric, some other muscles attached. Not too much. But it does form this suspensory sling. There's this sort of ligamentous muscular sling that suspends the larynx. The larynx sort of hangs from this sling that the hyoid bone is kind of the yoke that holds it all together. All right. So here in this diagram, you can see the real distinction between the upper and lower respiratory system. If you have an upper respiratory infection, it means you got like a head cold, right? You have something up in your sinuses, which I feel myself right now, maybe in pharynx. And if you have a lower respiratory infection, it's some sort of tracheal or bronchial thing you're hacking up. Anything? The sun. Well, there's this descending from the larynx, the trachea, your air tube, and your windpipe, and that's made up of about 21 semicircular cartilages. I say semi because they're not complete. Along the back end of the trachea, it looks like this. There's an opening across the back of the trachea that has a little muscular bridge, a smooth muscle bridge that can control the aperture of your airway. And then you get down here to the bifurcation of the trachea into the bronchus, the bronchi, this little V-shaped cartilage down there is called the carina, C-A-R-I-N-A. It just means, like sort of like the crown or the apex. It's the bifurcation of the trachea into the two bronchi. And then you have the right and left lungs, which we'll look at a bit more. So these are the models. There's another model. The TAs didn't lay it out, but it's over on the bench over there. I'll grab it in a bit, or Meryl can dig it out if you want it. It shows a little bit of the vasculature to the lungs, not that crucial, but a much nicer depiction of the lungs on the stand-up models here of the arborization of the bronchi and then the vasculature to the lungs. Okay, so here's a bit of the anatomy of the larynx. I promised you lots of cartilages, and here they are. So the thyroid is the big one that faces anteriorly. The cricoid cartilage is just below it. It's the next one down the chain. And the thing about the cricoid, unlike the other tracheal cartilages, which are incomplete, which are semicircular, the cricoid is like a ring. It's like a signet ring. It's a complete ring. And you can see how narrow it is here. And then as it goes all the way around to the back, here's the back of it, the cricoid cartilage. It's much thicker. So I guess the early anatomists or whatever who named it, when they had the thing in isolation, it looked like a signet ring to them. It was about that size, whatever, class ring. What else? So, yeah, there's the corniculate and the arytenoid cartilages. Those they're obviously very important to laryngeal apparatus, but fire on them. They are responsible for tightening and loosening what's called the vocal ligament. Now, the vocal ligament is your vocal cord, and this is a ligament the tension on that can be varied. So air that's passing through your windpipe, through the larynx, can vibrate those vocal cords, and it's actually the vocal cords that are generating the sound that you hear. So when you hear me talking, the larynx is responsible for what's called phonation, P-H-O-N-O-A-T-I-O-N, phonation. But phonation is not enough for speech. You need articulation as well. So it's the naso-oral complex that's responsible for articulation. So, for example, if I were to sing Happy Birthday, but only phonating it, it's going to sound ridiculous, but it's like ha 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 ha, right? So it's kind of like humming. It's just like, and you can vary the tone. The tone of your voice is varied by phonation, but giving that tone shape, the sort of windowing, the envelope, the audio envelope of that phonation is due to the mouth. What else? We can see the hyoid forming that sling, that ligamentous sling from which the larynx descends. Glottis labeled here as that void space between the vocal folds. It turns out that the vocal ligament is not the only ligament there. I think there may be another. Yeah, okay. So I don't label it. I took some of these labels out. But you can see there are two ligaments. This is called the vestibular ligament. And the vocal ligament is the one below it. So that's the vocal cord, the one that actually is vibrating. Speak. Here's a cross-section of the cricoid. You can see that it's narrow in the back, much thicker in the front, like a signet ring. Yeah, not a whole lot else I'm going to talk about there. That's the larynx. I'm probably going to skip it in lecture today. Okay, so here's the posterior margin of the trachea, like I was talking about. You can see here how you have the esophagus laying right against this trachealis muscle. It's called the trachealis muscle that closes off the back, I don't know, maybe 60 degrees of the tracheal circumference. And then the inside of the trachea is layered with this simple ciliated columnar epithelium, this layer of mucosal epithelium. So there are these mucus glands embedded in this tissue layer, and the whole surface has this charmingly entitled mucociliary escalator, these long cilia that produce mucus, trap particles, and then the escalator is constantly bringing it upwards. The cilia are constantly beating in such a way as to bring the mucus and the smudge up to the mouth. This helps us clear crap out of the lungs that we may aspirate. All right, anything else here that I want to make a point of? Tons of ligaments that I'm not going to ask you to memorize. You can go to medical school for that. Yeah. So this is kind of redundant, just another picture of the larynx. I don't want to spend too much time on the larynx. You can see the vocal ligament. So now the vocal ligament has been closed, it's been tightened and pulled closed, the vestibular ligament as well. These arytenoid cartilages, which are attached to the cricoid, they're the ones that attach to the vocal ligament, and they open and close like this, with that vocal ligament attached to it. Tightening and loosening that tissue. Seems like I've shown this picture already. What's going on here? Okay. Again, let's descend from the larynx. I had mentioned the carina. This is that internal ridge. There's this ridge of cartilage at the bottom of the trachea right there that breaks the trachea into these two primary bronchi, singular bronchus. They form the root of the lung. And I'm going to introduce a term called the hilum, H-I-L-U-M. The hilum is this portion, it's this region of the lung, but the word is a general term that we'll see applied to the kidney, and it's in other organs. It's basically the service access to that organ, if you want to think of it that way. Tubes don't come in random places. They all come in through the same portal, which we're going to call the hilum. So the root of the lung is one of these things. This is going to the hilum is going to include the all the blood vessels, the pulmonary and the bronchial vessels that are going to go in and out of the lung, and then any nerves that might go in there, whatever, along with primary bronchi. And just considering the bronchi, we call this the root of the lung, and then with the vessels, it's called a part of the hilum, significant a bit. This primary bronchi then begins to arborize, and each branching, we move up an ordinal step, right? So the next branching that we get past the bronchi, past the carina, gives us secondary bronchi. And then the next branching point will give us tertiary bronchi and so forth. I don't know how high people really count them. But here you can see a depiction of that arborization. So here would be the left primary bronchus with the next arborization into secondary bronchi. And then you get another arborization here into tertiary bronchi. And this calls them smaller bronchi. They continue to get down until you get to bronchioles. A bronchiole is an arborization that now no longer has any of these cartilaginous plaques on it. A bronchiole is similar, it just doesn't have any cartilaginous plaques. And we get to finally what's confusingly called a terminal bronchiole. We call it terminal because it's the last bronchiole on the chain, you'd imagine, but there's one further down that we call a respiratory bronchiole. And the reason a terminal bronchiole is not called a respiratory bronchiole is there's actually no gas exchange at a terminal bronchiole, so in that sense, it is a terminal bronchiole. It's the last arborization, it's the last structure that you're not getting gas exchange. So then finally, we get to these respiratory bronchioles, which are branches that are going to give us little pockets that we can get some air exchange, gas exchange with the blood in. They terminate in these little pulmonary lobules that have little cul-de-sacs off of them, these little bubbles coming off of them. The bubbles themselves are called alveoli. Alveoli, A-L-V-E-O-L-I, alveoli. Alveoli, I don't know where the emphasis is. I've heard it both ways. I say alveoli. And the alveoli is the principal. I'm sorry, I keep blocking me. You should just throw something to remind me. It's easy to forget. The alveoli are the principal respiratory organ, right? That's the site of gas exchange. So all of this here from like all of the turf of a tertiary bronchi, that's what's called a bronchopulmonary segment. So each each tertiary bronchi has a bronchopulmonary segment associated with it, and no other. So just looking at the lungs in the gross anatomy, we can see the different lobes of the lung. So the right and the left lung have different numbers of lobes. There's 3 on the right and 2 on the left. How do you remember that? I don't know. Maybe in this world, the world is biased towards right-handed people, so maybe they get the extra lobe. That's the way to think of it. But there's 3 on the right and 2 on the left. So there's a superior and an inferior lobe on both, and just the third on the right side is a middle lobe. And both of them, both the superior and inferior lobes on either side, are separated by what's called an oblique fissure. That name will suggest the disposition of the line. It runs obliquely between the two. And then that third lobe is separated from the superior by a horizontal fissure. So an oblique fissure, horizontal fissure between them. Kind of some anatomical minutia in terms of their names. You know, not something I would expect you to remember several years from now. But the tip of the lung at the top, the superior point, is called the apex, and then there's the base of the lung along the bottom that sits on top of the diaphragm, the pulmonary diaphragm. All right, so now we're going to look at the medial surface of the lung, and this is where that word hilum, it says Hilum on here. I've always said hilum. Maybe I'm misremembering that. Yeah. It's called the hilum in the kidney. Anyways, it says helium here. Regardless, I'll have to double check on that one. Maybe me making a mistake. But we can see how we have the primary bronchi coming in as the root of the lung here to the lung. And then we have the pulmonary arteries painted in blue because they are carrying deoxygenated blood from the heart, from the left or the right ventricle, but they are called arteries because it's pressurized blood. And then the pulmonary veins carrying lower pressure blood back to the left atrium. Not depicted here are the bronchial arteries and veins. So we have the pulmonary vessels that are bringing blood to the lungs to get oxygen. But the lungs themselves need their own blood supply. That's not the blood supply that keeps the lungs alive. That's deoxygenated blood. The lungs themselves, that lung tissue, has a totally separate layer or system of vasculature called the bronchial vessels, not shown in this picture, but we'll see some in a moment, that also goes in through the hilum. I'm going to continue to say hilum because that's how I know it, but until I confirm that this diagram isn't misspelling that. And then along this margin here, along the margin of the root of the lung, we see a cut layer of tissue. That cut layer is where the visceral pleura, the serous membrane that covers the lung, it's where the visceral pleura wraps over and joins in with the parietal pleura, which has been cut and removed, and would lay on top of that surface surrounding it as well. Okay. So just like yesterday on the pericardium, there was the epicardium or the visceral pericardium that was on the heart, and then many of you had these like flaps, like sort of nasty flaps up around the base of the heart near the top where all the vessels came off that were sort of waving in the wind. That was the parietal pericardium that was going to loop around and coat the heart. Okay, just like that. If you were to have a lung in isolation, that parietal pericardium would be cut right there. I do have a couple sheep's lungs that have been desiccated. I didn't bring them up because, I don't know, no one ever looks at them. They're kind of gross, but I don't know what there is to learn from them. But they are interesting to look at. Kind of looks like styrofoam. All right, so getting down into some of the microscopic anatomy, I don't know what X this model is, maybe like 100X or something. It's this thing over here by Katie and Haley. Now, we have a bronchiole up here coming down into a terminal bronchiole. These are terminal bronchioles right here. And then finally getting into a respiratory bronchiole. How do I know it's a respiratory bronchiole? Not just because it's labeled, but because I see a little alveolus. Alveolus being singular of alveoli, or plural. So there's an alveolus sticking off of it. That alveolus is where there's going to be some gas exchange. So this bronchiole is still a bronchiole because it's a tube, but there's some beginning of respiration happening there. All these alveoli are surrounded by little layers of elastic fiber and a meshwork of smooth muscle. And a respiratory bronchiole then further arborizes into what's called an alveolar, A-L-V-E-O-L-A-R, alveolar duct, with a T, not a K. Alveolar duct. Although if you got a lung infection, it'll sound like quack, quack. So it comes into this alveolar duct, and there are, an alveolar duct is kind of like the road that goes down a neighborhood heading into a cul-de-sac. It's not actually the end of, it's not the turnaround at the cul-de-sac, but it's that road that's going down into it, as if each of these alveoli coming off of it were houses or lots. So several alveoli coming off an alveolar duct and then terminating in what's called an alveolar sac. That's the cul-de-sac, the pouch at the end of an alveolar duct that has many alveoli sticking off of it. All right. And so then in this depiction, we have a large pulmonary artery coming in, and you can see those over there, painted blue, and then being drained by a pulmonary vein here in red. So lower pressure blood painted red because it's oxygenated. Now, those are the large vessels coming. There's also a much smaller network of vessels that are bronchial arteries, painted in red this time because it's oxygenated blood, but arteries because it's bringing blood from the heart, and then bronchial veins. And they're called bronchial because they follow the bronchial arborization, feed all that tissue, right? There certainly are lymphatic vessels. What else do I want about any of this? So we see here the visceral pleura laying on the surface of the lobule, the parietal pleura with its pericardial cavity. Pleural cavity. What was I saying? Visceral pleura, parietal pleura, pleural cavity. I think that's anything on this model. So this model is essentially reproduced in this thing over here. So let's see if we can identify some of this stuff. Without having it in front of me, it's a little hard, but this would be a bronchiole, some smooth muscle would be these red bandings here. The black would be elastic fibers. Bronchiolar mucus glands. Okay, so there in 9, there are these bronchiolar mucus glands that help to produce mucus for the mucociliary escalator. And this mesh of blue there, those would be bronchial veins. Bronchial artery, pulmonary artery, pulmonary vein. There's going to be some visceral pleura right down here. We have the epithelium and the connective right there. What else do I have? So this would be an alveolar sac, an alveolar duct leading into an alveolar sac. Those little bubbles are alveoli. Yeah. Take some time with that model. Shouldn't take you more than 5 minutes to get that one in your head. Different picture of the same thing. Okay. And Grace has, and over here, no, it's Grace. So in general, what my convention is here is we take material that hasn't been tested yet and we shove it to this bench over that way, and all the new stuff gets spread on these 2 benches. So if you ever want to review, usually it's going to get shoved over here. The pulmonary histology is on the slide on the deck by Grace here. So here's a cross section of the trachea. We can see the outer layer, this adventitia of fibroelastic tissue, and surrounding what's called hyoid cartilage. This is we see the chondrocytes in the little lacuna, the perichondrium, and the matrix of the cartilage here. So this is hyoid cartilage. Nice springy stuff. And then there's this mucous membrane. So there's connective tissue with a bunch of epithelium on top of it. The ciliated columnar epithelium on the outside that forms the mucociliary escalator. And then the seromucinous cells below that. That's where we're going to get the mucus glands of the trachea that are going to produce all this mucus that we are so blessed with. And then a cross-section of a lung. So here's some pulmonary tissue. Let's look at this. We have bronchial artery, bronchial vein. Oh, I'm sorry, this is a bronchiole. This would be a bronchial vein. Bronchus. And this section here is an alveolar duct coming down from some sort of terminal bronchiole, respiratory bronchiole. Let's see if I can find an alveolar sac. But off of this alveolar duct, you can see there are little alveoli all over the place. Each of these little holes are alveoli. This is probably an alveolar sac here, a terminal alveolar duct with several alveoli coming off of it. And it has this label as terminal bronchiole, respiratory bronchiole here that ends up in this alveolar duct, probably died in section alveoli. So actually, a fair bit of anatomy in the histology slides. And this is everyone's lung in here, I'm sure, because nobody in this classroom smokes. And you're all too smart for that. But this is what you look like, those who don't exercise such prudence. This is what you can do. So this is an emphysematous bula or emphysematous lung. This is what emphysema looks like. You can see here, how would you compare, just like qualitatively, how would you compare this with all the nice alveolar integrity, all those walls in shape, to this. I mean, the alveoli are kind of non-existent any longer. There's been a significant amount of tissue damage and rupture of walls left and right. You can see why does this person look like this? How did they do that? I already said it, smoking, right? So you see here all this black flecks, that's called tar. Smoking. So here's some more. We have significant destruction of tissue. You can imagine why it's so hard for these people to breathe when their lungs look like this. So that's it.